Hi, everyone. Welcome back to House Healthcare, Friday afternoon, our last budget discussion of the week. So Green Mountain Care Board is joining us. I think we have documents on the webpage, media page, and I'm just going to turn it over to both of you.
Great. Well, thank you, Chair Houghton and committee for having us here today. It's always enjoyable to get to hear your questions and answer anything that you want to know about. My name is Owen Foster. I'm the chair of the care board. I've been here maybe a year and a ish coming up on, and I'll let Jean introduce herself.
I'm Jean Stetter. I'm the Administrative Services Director for the board, which personal department means kind of everything back office. Everything back office.
So you pretty much run it, basically.
No. What we'd like to do is we have a presentation that I'm going to share, if that's okay. It's also available on your website. And what we're going to do is have Owen do a few pages of just introduction to the board. And then I'll go into the budget and our budget requests. And then there'll also be time perhaps at the end for more questions.
Okay, great.
I apologize. A number of you have seen sort of the overview, but it's always helpful to remind everyone what we do. Yeah, exactly.
We are very good at hearing things a lot of times, because then it sinks in finally.
So just briefly, we have 5 board members, and any regulatory decision comes before the board, and it takes 3 of the 5 votes to support something. So it's a pretty democratic process. The terms are staggered, meaning that the goal is to not have us all appointed by the same governor. Governor Scott at this point has appointed or reappointed all of us. Member Holmes and Lunge have been appointed. I think Lunge has been appointed 3 times and Holmes twice. The rest of us are newer. We're independent. We do not work for the administration. We often work with them, but we do not work for them. We do not answer to them. And that's, I think, in my mind, part of the genius of the board. You know, if you have one political person who can be a decision maker in a non-transparent way, it's easier to lobby and have the political influence on that. What we have with 5 people is we have to do it publicly, and 3 of the 5 people have to support anything that we're going to do on a regulatory. Quasi-judicial, that just means essentially that a number of our decisions have a judicial nature to them. People come before us, they submit papers, documents, evidence, arguments, and we evaluate that. We have to evaluate the quality of it. We have to evaluate the credibility of what people say, and we have to put it in context of everything else we understand about the healthcare market in Vermont. The main focus of our work is really on hospital budgets, accountable care organization budgets, and a slice of the insurance market. So we do not regulate primary care. We do not regulate independent surgery. We do not make rate decisions for mental health. We do not make rate decisions for primary care. Really, any of those things are not us. On the insurance market, the only thing we really decide are the QHP rates, qualified health plans, small group and individual. And on those, our decision-making is really pretty limited. There's a whole bunch of things that go into what makes an insurance rate go up. It can be how much the people who are members are using the health system. It can be the cost of the health system. It can be the cost of, and what I mean by that is how much more money somebody is asking for in their rate. So if you get paid $100 this year and they ask for a 10% rate increase, it's now $110. And then there's pharmaceutical costs. Those are very high. The 2 biggest components of a rate increase are really if there's an increase in utilization or the prices for those services. And in Vermont, we've seen the utilization be pretty flat and not really go up. The prices have gone up a lot. So to give you sort of a ballpark, 8%, 11% is the amount that we're seeing rates go up, costs, and utilization's around 2%, relatively flat. So there's not a whole lot we can do to get those insurance rates down if the inputs aren't down. And a lot of the inputs we don't touch. It's very difficult to get those where we think they should be and where Vermonters, frankly, I think deserve them to be, which is reasonable and affordable. We've seen huge rate increases in the qualified health plan space in Vermont. Astronomical, I'd say 45 to 80% increase cumulative over the last 5 or 6 years. In the last 2 years, we've seen insurance rates in Vermont go up around 28% in 2 years. So what cost you $100 for a premium 2 years ago is now $128. It's very significant. On hospitals, we really regulate the total amount of money that they can charge, right? And then we regulate how much they can get on charging more for their services. So the total amount of revenue, call that NPR, and then the rate, how much more are they getting paid for each service? And then ACOs, it's a pretty broad look at their operations and their costs and their productivity. Just to get a little bit more, the other parts, the non-regulatory parts, we have a lot of data analysis that we do. It's really, really useful. You can't make good decisions in policy or regulation unless you understand what's going on in your state and in your markets. All these things are interconnected. When we make a decision here, it impacts things over here. When AHS makes a decision on mental health, it impacts hospitals, right? All this works together. So understanding the system as an interconnected thing is really critical to making good decisions. We are nonpartisan. We do have all of our hearings are in public. All that means is that anyone can participate. It's my favorite part of the job. We have people that come to almost all of our hearings and they have public comment. And they'll sometimes have the best point of view that I've heard all day. It's really quite amazing. And they're really wonderful people to spend that time with us and to make our decisions better. We are not allowed as a group of people, the board members who vote, to work together to come up with what we're going to do before we do it. So that means I hear where the other board members are in public for the first time. So if member Walsh wants to do a very large rate increase and member Merman wants to do a really small one, I don't know that until we're literally live on camera in front of a whole lot of people. And then we have to sometimes figure it out with very divergent viewpoints. And the divergent viewpoints, I think, is really important, right? Because everyone has a different perspective, and you all do this every day. And hopefully the goal is to make it a better end product for the people. Accountability, I want to touch on. I think this is really important. I want the care board to be as accountable as we can be. What that means is if our mission, just to remind everyone, is affordability for healthcare, access to healthcare, and quality for healthcare, right? We want to be as affordable as it can be, and we want to be able to get into the doctor, and we want to be a good, high quality experience, the care that we get to be high quality. And we need to be accountable to that, to the people and to the legislature. How are we doing on those things? Are we doing a good job on affordability? If rates go up 28%, it's a fair question if you're doing a good job, and we have to explain that. And sometimes you let rates go up because you want to ensure there's access. If rates go down too low, you might impact your ability to get into doctors because they'll close, right? And they might not be able to buy the best equipment. So just balancing all those is what we're supposed to do. And keep in mind, like where we sit is at this really tricky intersection of people who are paying. We need to be very serious about watching how much money we're charging them because there's such downsides if we charge them too much. Their deductibles go up, they avoid care, they don't get care, they don't get preventative care, they avoid doctors because they got a $10,000 deductible and they can't pay it. So they're like, I'm not going to go get that MRI. I'm not getting a colonoscopy. I don't want to pay it. I have the money. So it's not just give more money. There's downsides when you give more money. We have to be mindful of those and vice versa. So it is a tricky spot. So you have that. You have to make sure the hospitals are stable and sustainable. We don't want closures. We don't want bad service line cuts. And then we also have the broader system, mental health, primary care, everyone we don't regulate. If we give huge amounts of money here, does it impact the ability for the rest of the system to have enough money for them to be sustained, right? And in Vermont, I think there's probably very broad agreement that some of our problems in healthcare are pretty defined, and they are mental health, long-term care, and primary care. Now, there's others, but I would say that most people generally agree that those are our three biggest challenges. Without those, you have less access, you have less quality, and you have huge sustainability problems for the whole system. The hospitals need those systems to be sufficient. Otherwise, they have all those problems that they have to foot the bill for. And that just makes the affordability problem worse. So in my mind, I know you guys hear about healthcare reform all the time. The biggest thing is solve those three. And from there, we could start making some progress. And I'll turn it to Ms. Stetter.
Thank you. Thank you. So if we're looking here, the biggest thing with the Green Mountain Care Board budget is that 40% comes from general fund. You say, what is our source of funds? How are we paid for? So throughout my time at the board, since the board's existence, it has been 40% general fund, and there's been different pivot points where the legislature has always come back to agree that it's 40% general fund. The other 60% has varied over time. Currently, it's 60%. The phrase is called bill back, and essentially what that is there's different ways that regulatory agencies pay for their work. DMV has license fees, there's all kinds of different ways. And one of the tools that Vermont uses and other states use is called a bill back. And essentially what that is we charge the entities we regulate a portion of our budget. And so the legislature has agreed that 60% of our budget is basically funded by the entities we regulate. For our FY25 budget, Chair Foster was very clear that because we're holding the entities we regulate to a budget, that we wanted to follow that as well. So we met the GovRec 3% recommended increase. As I'm sure you've heard from everyone else who's come in, what that looks like is cutting other expenses in order to pay for the salary fringe, which is largely health insurance. And so that's what we did. In terms of staff as a board, we have had and continue to have 32 positions. 5 of those are board members, and then we have 27 staff. We recently converted a classified position to a staff attorney position, which I think is wise and well needed. Our regulatory season is incredibly short, and Chair Foster could say it better, but basically if the hospital budgets drop on July 1st and decisions are due September 15th, there's like 14 days, a very short time for our staff attorneys to put out 14 different, very complex budget orders. Is there?
Let's give you a sense of like the work. So if there's 14 hospitals, 15 with retreat. In that period of time that Ms. Sutter was referring to, you have 14 hearings from those hospitals where they present their evidence and why they think they should get the rate or budget they want. Then you have 14 sets of deliberations, right, where we figure out what we're going to do, 14 votes, and then 14 written opinions. So 2.5 months, $3.6 billion of requests, hundreds of millions of dollars of increased costs, and 2.5 months for those 30-ish hearings to be held. The hearings can vary. Some will be fairly short. So like a smaller hospital, Gifford, who hits their budget guidance, we give out guidance every year. Hey, we think that this year you should have a rate increase around 4% and a revenue increase of 4.5%, something like that. If they hit those targets, it can be an hour-long hearing, a half-an-hour hearing, 2 hours short, like pretty simple and a pretty easy vote. We almost always approve those pretty easily. And then if there's a large rate increase far above what the guidance is, that is a much longer and more arduous hearing for everybody involved. And those can be, I think this year we had one that was 9 or 10 hours, 8, 10 hours, very long. And that's difficult on the staff, it's difficult on the board, it's difficult on the witnesses, but it's very significant, right? Like if you make the wrong decisions, they should have an opportunity to really be heard. So anyway, it derailed a little bit.
So, long story short, no position changes in terms of total positions, and we chose to forego classified positions for our staff attorney. There are, a couple things in terms of the context of our budget that we'd like to review. The legislature gave the Green Mountain Care Board and AHS a total of $5 million for hospital sustainability. Of that, the Green Mountain Care Board received 4.1, and we've been doing a lot of work on that. So I'd like to have Chair Foster take that up in a minute. Data stewardship and governance. The thing I wanted to highlight here is the Green Mountain Care Board has a data governance council that in terms of how we responsibly manage the healthcare claims database that we have and also the hospital discharge data. And I just wanted to highlight what a leader we are in the state. Other agencies have copied our data governance council as they're thinking about how to thoughtfully and responsibly. I'm sorry. I'm hard. I got nervous. So responsibly, it's just me being nervous. Responsibly manage Vermonters data. Chair Foster also, if you heard him in the beginning, talked about how we currently, like everyone in Montpelier, we are currently displaced from the flood. Our office, as you cross the bridge from the highway and turn right, we're the second little one-story building, or we were. It looks like a refurbished Pizza Hut. We had well over 5 feet of water. We very carefully move things up. Best laid plans. We thought we were okay, and 5 feet of water, and in a one-story building that doesn't have a basement, we're not going back there anytime soon. So we're temporarily. We have about 6 cubes, a few more that A&R has been very generous to share with us. But we're part of the kind of displaced population. The other thing I wanted to talk about is part of our budget that we have here is we have, and I can go to the ups and downs too if you want, but one thing I wanted to, let me pause. So our ups and downs are not very interesting. It's basically what I just described. What is new this year is that we have a proposed bill back language change. And I wanted to keep this slide up because the change that's being requested isn't changing this. We're not asking for any more money. The state will still pay the 40%. And it is a shift to how the 60% is calculated. And this has changed over time. Our goal with the language change we have is that we leave everyone as they are now, the regulated entities that we pay, that pay us, that we regulate, they pay us for the pleasure of being regulated. Leaves everyone as they are. And our goal is transparency, simplification, and a clear understanding of the assessment that we're charging the entities we regulated. So, our primary bill back goes to Vermont's 14 hospitals, the insurers, and the accountable care organizations. The funding formula had stayed, just a brief history, funding formula had stayed static. One of the insurers was unhappy with it. So at the end of a session, there was a 1-year change that basically said, this will sunset after a year. All the stakeholders have to get together, agree on the new plan, or it's going to revert back. So when I joined the board, they were working through that. And the stakeholders were Healthcare Advocate, ACO, FOS, the Vermont Hospital Association, the insurers, primarily Blue Cross, also MVP, and the Green Mountain Care Board, as well as Joint Fiscal Office. So there were 2 things in that change. The first was that for the bulk of the bill back, everyone agreed on what the percentages should be. It was 10% ACO, and sorry, I don't have it all committed to so basically, we all agreed on the percentages, and then we agreed to, and then we also agreed to, as the first step, to do something a little bit fancier, which was trying to incent the regulated entities to, kind of present more concise information. And so with that, it was saying that we're gonna track time and labor for reviewing each regulated entity and the direct contracting costs for that. So that would be the court reporter, that would be any actuaries used for insurers. So we did that, and so the intent was 40-60 all the way through. We have this kind of direct piece, and then the remaining percentages was agreed to with all stakeholders. Long story short, a few years down the road, what we've come to realize is that direct portion didn't move the needle too much. And for an organization that's going for more transparency, it just made our calculations, kind of more difficult to follow. So after talking to the regulated entities and the healthcare advocate and checking in with joint fiscal, we together agreed on a language change, which looks like a slight tweak to the percentages. And we were originally going to propose not tweaking the percentages because the change was so small. However, that meant that even on a small scale, there were winners and losers. And for everyone to come to consensus, the small tweak is needed.
Okay. And do you have those percentages? I'm trying to find them as you talk.
Oh, I'm sorry. Here, yeah, let me just, sorry. It's in the language that I believe should be, hold on one moment, please.
I don't think it's.
Yeah.
Okay, well, I have it, hold on one sec.
Is it in the governor's recommended budget language?
Yes, but our tweaks, I recently adjusted. So from the governor's rec, and what you'll
Okay.
see is here in the red, I left it redlined.
We're not sharing yet.
Oh, okay. Gotcha. Oh, that's because I apologize.
No, take your time.
That's my technical challenge. Just one moment. I was sharing just the window and
Oh, right, yes.
screening, so I apologize.
No worries.
for not being as fancy.
Okay.
See this here?
Yeah.
Okay, so what the long and short of it is, that H1 is the actual or direct, so we're proposing to strike H1.
Okay.
Just go back to one step. And so the percentages here is what we agreed to as a consensus.
Okay.
And so what came out of the years that we did the direct calculation is that the Green Mountain, the work to regulate the accountable care organization was more than we estimated. When we were doing this, the ACO was brand new, so it was just a rough estimate. And so by increasing the ACO, which gets it to basically where it is now, that results in a small adjustment for the hospitals and the insurers.
And so have the hospitals, insurers, and the accountable care organization agreed to this? Everyone has agreed to
Where's
it.
the insurer?
Three.
They have a long, Rexina,
Yeah,
very
yeah.
long description. They're this one,
You're lumped in with the nonprofit hospital and medical service corporations
yes. So,
and HMOs, all that. You
yes,
still have them?
yes, yes. So, there's technical categories for insurers, like Blue Cross itself is like its own category. Not, and then their HMOs separate.
So I think the key for us is we're still keeping the 40% out of general fund, which we always had. We're shifting a little bit on the percentages of the 60%, and all of them agreed to it. That sounds good to me.
Sums it up.
Hold on, Leslie and then Brian.
I'm just curious to know the difference between in two, a hospital, and three, a nonprofit hospital and medical service corporation.
Um. uh, This is an insurer, Blue Cross. And the hospitals, this section 2 is Vermont's 14 hospitals. Section 3 are all insurers. And I'd be happy to get back to you with the exact technical
No, that's fine.
insurance.
So what you're saying is a nonprofit hospital and medical service corporation is an insurance company.
Yes,
That's all I need to know. Thanks.
thank you. Right.
Yeah, I was thinking of it as payers,
Yeah, payers,
Versus-
good.
but and look, so we're shifting the cost slightly from providers and payers to ACOs.
Yes.
Right.
Based on what our actual experience has been in this period that we've done the calculation this way.
Yeah, I understand it, and it sounds like everyone agrees to it, so I don't. Unless there's some scandal like arises, I don't know why we would have concern, you know, like.
If you do the math, it's 2% more, 1.2%.
Yeah, exactly.
0.8 there. It's-
Yeah. It's very simple.
Anyway, so any other questions on the bill back? And otherwise I want to go back to one thing. Okay, we're all good there. So when you said that the all funds, so your increase was 3%, but you have reduced some expenses other places. So are you level funding your budget?
Yeah, we are not level funding our budget, we're up 3%.
You are up 3%.
We're up
Okay.
3%. And here, I'll just go back and share the ups and downs. What we did do was we met the governor's
Recommended 3%. Okay. Yeah, it's in the presentation.
Oh,
Here's our, the very detailed ups and downs that I'm sure you're used to seeing. Long and short of it is this large section here shows what we did with salaries and benefits.
Yep.
Operating expenses. The biggest change here is you can see that we eliminated fee for space because we tried to get in state-owned space.
Right.
It's not available right now. So we're looking at leasing. And then contracts, we had to adjust down to meet our recommendation.
Brian?
You may not know the answer to this, because you explained that the 3% was guided by the recommend, but I'm curious, we've been hearing that number a lot. Do we know, and actually Nolan might know, but do we know what the inflation was in the last year? And do we know what the cost of living increases over the last year?
More than 3%.
More than 3%.
Absolutely.
Thank you. Well, we can come back to that later.
All right, any other questions on I know there's some more slides here. Questions on the?
this is very, very minimal. But sure, but where do you live in the agency? Where do you live in do you live in HS or where are you?
We're a free bird.
Got it.
Yeah.
That's all I wanted to
Try
know.
to stay hidden.
Yeah,
Yeah, that's good.
the answer to your question is if you're trying to look in the big executive budget book,
Yeah.
which they've made easier to search recently.
Yes, they have, yeah.
We are under the AHS folder, like the rhyme and reason of those folders doesn't always make sense. Like the PUC is under law enforcement or something, but we're under AHS in that particular folder.
Okay.
Yeah.
And as an organization,
Yeah.
you are outside of any agency because you are
Separate.
That's where your budget lives. So.
Yeah.
So we're not here concerned about that 3%?
if you are concerned about it, then ask questions, yes. Yes, I mean, this is our budget to approve.
It is our budget.
Absolutely, yes,
Okay.
yes.
All right.
Yeah.
Do you have concerns?
Pardon me?
Oh, do you have concerns?
Do you have questions?
Well, no, I have no questions. I just want to make sure what we're
Yes.
hearing is for us.
This is for us.
Okay.
Yes.
So as I understand it, you've kept it capped at 3%, but mainly that's savings because you don't have a place to be right now?
No, we budgeted for least costs.
Okay. I'm just seeing like the down on the fee for space charge.
I guess what is fee for space, which is that your leasing? Like,
Oh,
you used to rent your place?
So I'm not sure if my mouse is showing up. Fee for space is if you're in state-owned space, that's BGS language for your rent. We have a down here, but you'll notice we also have an up for
Oh, rental.
$102,000 for the rental space.
I was concerned about you coming in next year's and you're gonna be way up because
Great
you actually
question.
have a place to be.
Yeah, we would be very, yeah.
Okay.
We
I see
do,
the offset.
and yeah, so. Sorry?
Can you go into contracts a little bit more, describe what that is, and if you have a $75,000 less, are there contracts that you feel like you need that you won't be able to?
I appreciate I appreciate that question. So, in this case, we felt like it was, an achievable goal, based on the overall work, we've done to balance our contracts. Getting a 3% increase after years of level funding, is a positive. So we've been working for years to really efficiently manage our contracts. Our contracts are, we have contracts for each area of the regulatory and other work that we do.
Consultants,
Yes.
attorneys?
We don't contract for attorneys at all. For the rate review team, we have court reporters across all our regulatory work. For rate review, we have actuarial contracts, which are, the actuaries are required to help us understand the insurance rate process and make sure it's completed accurately. For hospital budget, we do have a hospital budget database system that basically Excel, was no longer serving to have all the hospitals send Excel spreadsheets up. So we have a database program for them. For data and analytics, we pay for the operation of the Vermont's claims database, VCures. We pay for the VUDS database, the hospital discharge database, and other data and analytics work. So those are examples of the type of contracts that we have.
Any other questions on the budget?
This will put some of the budget and the work in context, I think. One note I just want to say, when we lost the office, I think we had a hearing that we conducted the very next week.
Yeah.
I don't think we never missed a hearing.
Right.
So
Yeah.
days later, we were conducting hearings. We never missed anything. And just for the scope of what we do, I think we have 50+ hearings a year, 54 hearings a year. So they can be regulatory. We also do things to try and educate ourselves more about the system. So we had a series of roundtables on primary care and suggestions from experts on how we can improve primary care. We had a roundtable set of 3 presentations on what people call the cost shift from leading academics to further understand that theory. And so anyway, that's a sort of scope.
Can I pause on that? At the back of our presentation, we do have a resources slide.
Oh, great.
So you can go to meeting information, see, this is 2024, but we can very easily get to last year and be able to watch anything that is of interest.
Thank you for putting that all in one place. I like when people do that because then members of the public can find it easier.
Yeah. Thank you. Yeah. Sorry, Chair Foster.
No, no,
I
just
didn't mean to
The-
interrupt.
The annual report will have a pretty good summary if you want a sense of what we've been doing as well.
Great.
So Act 167, this is the big reform effort work that was put in 2022. This added a lot of work to the care board, a lot. And I know just because our staff's great, how much additional work that was. We did not ask for another person, no growth in our operations through that work. There were funds for contracting resources that were used, and you can see those here. So the main one that I want to flag is this community engagement to support hospital transformation. So money's hard to come by, as you all know, and it's a frequent topic in this building. And so when you have money and it's limited, you need to think about how you use it. And it's really, how do we optimize our allocation of our money in healthcare? And are we getting what we need for that money? This effort was to understand what resources we have, how they're being used, and what we don't have. And so we hired a team from Oliver Wyman with whom we work. This was really Member Holmes's idea to do this work, and it was a great idea. I think it's some of the most important work we're doing. And he has done, I think, we have it here, 100+ meetings, 1,800 participants. This includes folks that have been disadvantaged, it includes hospital executives, everybody we could possibly reach out to and get to participate to inform him of what we have in the state and what we need in the state has happened. The next thing that's happening is he is going out and meeting with leadership and communities with a set of recommendations that he has come up with for what Vermont needs. He has called our system in a public hearing recently, which caught my ear, dysfunctional.
We would agree with that after our testimony this week.
Oh, my God.
It's a big word and it matters a lot because nothing else is going to work when your system is dysfunctional. And I think what he means by that is that we don't have a system that's working together and we don't have what we need where we need it. And so his recommendations will be for transformation. Are there opportunities to reduce costs so Vermonters can afford healthcare by reducing redundancy, by reducing infrastructure, by sharing resources? But not only is it a reduction thing, which it may or may not be, I do not know what the recommendations are. I don't even know if he does yet. But it's also adding what we need. So do we have primary care in Southern Vermont where we need? Do we have substance use treatment in Ludlow? What do we have and where? And let's add the things we need so that we're actually using these dollars efficiently. So that's what this set of work is designed to do. And just for process, which many of you are familiar with, he's going to take these out to the communities. Communities will have input and discussion on it. And then there will be a report. It'll be submitted to you all, to us. And then the local communities and the boards of the hospitals will have an option to take or leave whatever they want in the report. They may do none of it. They may do all of it. There may be some state things that need to be changed, like licensure or like EMS or transport. It's going to be pretty broad. But I think it's really critical that the work gets done. And then the other big one on here is really the subsequent all-payer model agreement, which is ahead, which I know you've all heard about, and a global budget and whether or not the state is going to pursue that. I believe we will be applying on March 18th. Then we're in a very intensive negotiation period to see if we can make it something that is optimal for our needs and if it's something we should pursue.
Yeah, Art and then Leslie.
What date did you give just now?
So for the subsequent all-payer model agreement, the far left, that's work that's being led by the Agency of Human Services and the Director, Pat Jones, of Healthcare Reform. The application that we submit will be March 18th. And then we negotiate for a period of months, and the state will submit a methodology for how a global budget, one chunk of money, will be calculated for hospitals. And then
For Medicare.
for Medicare, correct. We do not have a commercial model at this time, and then AHS and DVA would have their own methodology for a Medicaid.
Yes, which is what we heard about earlier today. Leslie?
I'm just curious to know who the we is in the negotiations.
Yeah, it's AHS is the lead, and the Care Board collaborates, is the language in 167. What that means in practicality is we work together on it.
So there'll be people from each place in the room with from the feds. I'm just trying to pick that,
Yeah, probably on the phone or Zoom, but
whatever,
yes, there'll
the
be.
room.
I presume, I think they know who the negotiation teams are. I think it's myself and Member Lunge and Secretary Samuelson and Director Jones.
So at least those four, that's who's representing us.
Correct.
Thank you.
I'm gonna ask a question about overall budget. Yeah. So 3% is
underfunding or defunding essentially year over year. So what is not getting done, given the workload that I've witnessed you doing for Act 167 as mandated in my community and certainly across the state? I appreciate the role that you have, not just in Act 167, but in the broader scope of advancing our system of care for all of us. And so I'm deeply concerned with that defunding, and I'd like to hear some examples of what is not getting done in FY 25.
Good question. So the defunding is not just not keeping up with inflation, it's also the additional workload, right? Because when you do more with less, you're also effectively defunding. What we tried to do to handle this is a couple things. We are refocusing some of our resources, just in the office reorganization of how we run our office and how it's structured. And what we did was we put more people and resources towards some of the hospital budget work. It's the most money, it's the most complex, it's the most charged, it's the hardest. And so we try to put more resources there. Another thing that we're doing is care board members themselves. I don't know if labor is the right word, but we're trying to take on a lot more of the substantive work as opposed to just reviewing it. We're trying to chip in quite a bit. So Member Lunge does a lot of the global budget work herself. Member Holmes is doing a lot in community engagement. I'm an attorney. I work with the legal team. I write opinions. I do a lot of legal, not a lot. It's my favorite part of the job. It's learning from our lawyers because they're awesome. So we're trying to do that to not do things. There are a number of things that I'm disappointed that aren't where we would like them. So for example, evaluation. So have you guys seen an objective evaluation of the all-payer model for the state of Vermont? No. We haven't. We don't have them. We don't know what it did.
What do you mean by evaluation though?
Subjective.
How things turned out? Like, did they work? What were
Is there an audit from the auditor about it yet?
We have a letter from the auditor from a couple of years ago.
Okay, so there's not an audit yet.
And there was the analysis by, I forget the agent.
NORC,
Yes, thank you.
and that's just Medicare. And so Medicare, the federal payer, no offense to them, but I care least about them in some regards, right? Because for Vermont, they're the least of our money. Commercial is all of our money. Medicaid is 50% of our money. Medicare is a lesser amount of our money. So how are we evaluating the impacts of our reform and all of our work, all the care board's work, on that set of people? That work hasn't been done. It's something I would love to do, but we simply don't have the people to do it. Affordability, access, and quality, we don't have affordability measures. We don't have a clean and clear, here's how we measure affordability, here's how we measure access. And it sounds like a simple thing. How do you measure it? It's very complex, right? So we have things that we look at that we balance our decisions on, like the underinsured rate that you get from the household surveys. If we're going up too much in expense, underinsured goes up. So that's something we can look at to kind of ballpark how we're doing on affordability. Simply how much our rates going up compared to wages, that gives you a sense of affordability, right? So there's factors that we consider, but we don't have like a defined affordability metric or access metric. We have huge access problems in the states. So people say we're affordable Medicare state, but you have to keep in context that we're the healthiest state in the United States. We're generally considered the healthiest. And we have very low utilization and difficulty getting into the doctor. So we have extremely high commercial rates, but we don't see doctors and we're healthy. So that's even higher, right? When you normalize it for those. I would love for the state or the care board to do a better job of evaluating those things. So I guess that's my answer.
Okay.
So I don't expect us to figure this out in 5 minutes, but it would be helpful over the next year maybe to think about how we could support the Green Mountain Care Board and the healthcare like regulatory system or whatever you want to call the whole, the machine behind it all, the ACOs, the payers, et cetera. Like, how could we support developing like some kind of evaluation and data collection infrastructure? So I don't know if that's the right way to put it. Some way to regularly be measuring progress, especially when it comes to affordability and access, because it does concern me to hear you say that it's hard to measure that there's no real solid process for measuring that, yet our goals and statute still that started the Green Mountain Kelly Act 48, it talks about those things, so I hear you, and I'm just, I guess the question is more like, you don't have to answer today, is how can we work together to develop those evaluation methods?
So I'll say it's something we are actively working on. It takes time. We've got people working on it today, yesterday, every day. The other piece is it's not that there isn't any, it's that it's not formalized and we don't have like a really consensus way to do it. And then evaluation and access is broader than that. It's also, what is our system doing? So we hear all these things like hospitals are underfunded, or we hear that there's no long-term care, or there's not enough primary care. What's our data to understand those? You hear this every day in these halls, but what's your data to show that? And what is it doing temporally over time? That's what we need to see. Is mental health going down, and how are we thinking about it rather than talking points or sound bites? Objective, clear evaluation of these things we all know. Does that make sense?
Yeah.
Go ahead. Oh, I'd say you hear a few of them because I know, the AHSBA is coming in with, again, skilled nursing facility support. I know EMS is coming in, across the state, but that's anecdotal.
Right.
As opposed to like what's happened in the system and what you can't see that's like a simmer instead of a boil.
Right. Yeah.
Or lack of better.
How can we be more proactive looking at the system of care and where we, instead of always,
Yeah.
So we've been working on this, I call it like state of healthcare. And when we came into HROC and we came into the joint committee, we had a whole set of slides on what our affordability is doing and those things. And we're trying to improve that. That's an area where we are limited in resources. And it's been, as we prepare for things, we focus and try and understand more. But I think a more global effort on that would be beneficial because you're making decisions. You need this.
All right, and then we'll close up, or not close up, but.
I assume all that we just said in the last few minutes has to do with the dysfunction that the individual that you said that had in mind when he said it. Is that a fair statement?
Yeah, I mean,
I'm really like to get at the dysfunctional statement because I think that is key to what we're trying to fix.
My takeaway from his statement of dysfunction was, one, it didn't shock me because we know that we have, you'll hear from the hospitals and they'll correctly tell you about their problems with borders and people living in EDs because they can't send them to long-term care. And you'll hear from the hospitals accurately and correctly that they're getting people who can't go to primary care, so they just show up at the ED. That, I think, is the dysfunction that he's referring to. Is the appropriate care in the appropriate place.
Okay.
If you're not doing it in the right place, it costs you more money. And there's also a level of humanity.
And I think, just one follow-up to that is I think there'll be an opportunity for you in the second round. There's 2 rounds to community engagement. So hopefully you've heard about the first one. And now there's data work being done to prepare for the second one. So there will be a second round of community engagement meetings across Vermont in late, May. Some of them may overlap with the end of the legislative session, which I know is difficult for you, but you can zoom into any of them. You don't have to be in person. And I would encourage you to participate, ask your questions, because you'll be able to get it directly from him. And we're not scripting Oliver Lyman or, anyone that's working on it.
Yeah.
We're getting ready.
Melanie?
I just heard you mention the household survey as a metric that you use. How much do you depend on the data from that, or is that?
I would say, going to Reverend Sina's question about it, well, how do you do this if you don't? That's one of the things, one of the tools we look to is where is that underinsured number going? So I would say I probably reference it 5 or 6 times a year. I mean, I know the numbers that matter in my head. So the underinsured rate is 44%, right? I know that number. I know what it was 3 years ago. So yeah, those numbers matter quite a bit.
And I think the reason Melanie asked is we've heard over the last couple of days that it's not fun. This would be the next year that it happens again and it has not been funded. So we're we're adding that to our potential list of things that need to be funded.
Right, the last one's 2021.
Right, it's supposed to
There's
be
always-
every 3 years.
There's always a lag.
Yeah. But it is pretty valuable, I think. Yeah.
I agree.
Great. Leslie?
So just thinking about the evaluation process that Casey brought up, is that going to be part of the negotiation? Do you think that could be embedded in the all-payer conversation?
I think it will be naturally in that there'll be targets in the agreements and like what we're trying to shoot for in terms of total cost of care, Medicare increases. So on that, what we don't want is we don't want expense growth to all shoot out on Vermont's limited commercial insured population, right? Those are just our small businesses and people. So we need protections to make sure we don't save Medicare money and it comes out of our pockets in the commercial market. So I think there'll be those kinds of targets that will be negotiated. So yeah, that would be something in the evaluation. I think there's a couple things. One, how is this working? Are we losing access because it's a cost containment tool with a target and you get more money if you save money? What can happen in that? You just give less care. But we have utilization problems. So we need to make sure we have ways to evaluate whether or not that happens. So for example, I don't want to take too much on, but I find this interesting.
Yeah.
You don't want to have a small hospital say, this patient's too complex. They got to go to UVM. We're bumping up against our cap. This one's too complex, go to UVM. And likewise, you don't want UVM to say, this one's too simple, go over to Copley, right? Because there's different types of hospitals. So how do you evaluate whether or not the right care is going and utilization is not being impacted to achieve targets? That's an evaluation you have. And I guess the last one I'd say is, what's the evaluation we're doing to decide to do it? Compare it to the alternatives. Compare the administrative costs. It's very expensive for a hospital to change how they budget. Think about that. Some of our hospitals are very small. Can they afford and how are they going to pay for that change? And are they going to have two budgets? They are. They're going to have one for fee for service and one in global. What does that do? The care board's contracting. What's that going to cost? Everyone's costs to do this need to be thought of and considered. And then what's the opportunity? There's huge opportunity. And we just need to see all that.
Yeah, and you kind of dovetailed with my question. I see healthcare and pardon me, not meant to be an insult to any healthcare provider, but it's this big ball of yarn that's just so interwoven and, for me anyway, very complicated and hard to understand. There's so many agencies, so many groups, so much embedded stuff. Do you feel at this stage that we can do enough to make a difference in what it costs ratepayers, patients? Can we get at this fall and make the changes that the $5 million were given to do? I get very concerned because you just kind of talked about some of it that might not be able to do much, and maybe what we're doing is the best way. I don't know. I mean, I know that's probably keeps you up at night thinking about that very thing because this is very hard work, very tough, I would think.
It is, so I was thinking about that this morning, actually, when I was walking. I don't think, everyone says it's so hard, but there are kind of things that are right before our eyes.
Yeah, okay, I'm sure.
They're not that hard. We need to support primary care. That's not that hard. It's been underfunded. Compare what it gets, primary care, to other parts. It does not make a whole lot of sense. The margins that somebody gets on ortho or something so valuable to the community health, population health, like mental health or primary care, is so low. That makes no sense. It's not what we want. So we have to fix that. Pharmaceutical costs are very easy. That's a hard one to fix, especially for the state's authorities. And I was thinking about Governor Scott and Bernie Sanders. Some of these people are really successful and they have like a couple limited issues that they want to fix. They haven't really fixed them, right? Governor Scott wants affordability. Bernie Sanders wants income equality. I don't know that they've gotten that far. No offense to either of them. They're wonderful politicians and amazing people and have amazing teams, but it's for whatever reason, things that shouldn't be that difficult to achieve are. So I don't know that the solutions to either their main focus or ours are that far from our eyes. It's just getting over the things in the way of doing it.
And the second thing, just quick follow-up here. How are you doing with the expenditure of the money we gave? How is that? Or do you keep track of it? I assume you do.
We do. Yeah.
Maybe I should ask you that.
So on the cost thing that you asked, this year, the board had larger reductions from what was asked for than historically. So this year, the care board gave across the system a 4% increase to the hospitals. That saved Vermonters $175 million. That got rates lower, right? And so we're trying to balance everyone's sustainability with that affordability. So this year, I think we got it as good as we could. And so there's that. We have saved money. $175 million is a lot of money for our ratepayers to save. That's a lot. And then in terms of like community engagement, I would say the work we're getting from Oliver Wyman's a fixed contract, flat fee. He's done phenomenal work. You saw the volume and scope and breadth. He's going to have recommendations. So whether or not there's an ROI on that money depends on whether or not anyone does anything with the report.
Okay.
So, and one thing just to add on to that is specifically why we chose this particular contractor is they did a rural transformation in Pennsylvania of the Geisinger
I think you said that
system. So they
before.
had specific experience working with, it's not the same as Vermont, nothing is, but it's a similar thing. So we were very thoughtful in kind of who we chose for that piece of work.
So at this stage, you think the 5 million is enough to do the whole job?
No. Because there's still a transformation to be done. And then for the all-pair model agreement, we don't know if we're doing it yet.
Right, so you're proposing what you propose with the
Right.
5 million.
This
It's
money.
up to us to make that decision. I guess so. Okay.
Okay, so we have two more and then we need to move on because we are doing more work. Alyssa and then
You
Brian.
know, to your point of answering Art in, primary care, mental health. I always think of it, it's all what we value. We pay an amount because we value it. And we can say we value things, but if we're not paying that, then we really don't value it. The Green Mountain Care Board has the authority to set rates, not insurance premium rates, but provider rates, reimbursement rates. Have you considered this? Or have you considered, when you're doing rate reviews for the insurers or the hospitals, that you set it so that they have to pay, 12% of their costs need to go to primary care or something like that? What's Green Mountain Care Board's actions on that?
That's a really, really great question. So two things. One, in terms of the insurers, this year, for the first time, we put in an order for the insurance companies that they had to lock their rate increases. So there have been two systems. Hospitals would get the Green Mountain Care Board rate by and large, which were 10%, 9%, whatever they were. And then the insurers would have less money to give out elsewhere. And so you saw two systems where hospitals were getting very large increases and others in the system were getting low, 0, 1, 2%. And we said that doesn't make sense. So we ordered the insurance companies to award their rate increases based on access, quality, and affordability. We want alignment. If the hospital is giving services that are the best and the most affordable and give good access, give them the higher rate. If there's an opportunity at the primary care to do that, give it to them, right? Do it based on a way that makes sense for what we're trying to achieve. In terms of the rate setting authority, yes, we do have the rate setting authority to say provider A gets this much, B gets this much. In terms of Representative Rebecca's questions, resources, that's a very expensive and complex thing. That's another thing that we're leaving on the table. And your last question is, are you considering it? 100%. That's one of the reasons we moved we added a lawyer. So losing classified positions is bad, and Susan has pushed me on that a lot. And I said, we can't possibly consider some of these things without that legal resource. It's a whole rulemaking process. It takes a year. Then you've got 10,000 CPT codes, whatever it might be. How are you going to do it and do it equitably and intelligently and fairly? And everyone says, give more money here, but every time you give more money to this, you're taking it from here. And that's a dangerous thing that needs to be very intentional. So yeah, I really would like to do it, actually. That's the answer.
All right, last one, Brian.
Trying to make it as simple as I can. You were talking about when you were talking about elected leaders and their calls for certain policy changes like affordability or income equality, I think you said. And you said they have good ideas, but no one's been able to achieve these things. It just made me think about why. And my like take on it is that we've built our entire economy in an unsustainable way because we don't look at the true cost of anything. That we could create these like social controls of what the cost is, and we stop there and we don't go further. And I guess my question would be, do you see ways that we could like empower the Green Mountain Care Board to go further and look at the true cost of the healthcare system? And I think you get, it seems like you get what I mean, but like, do we look at the cost of their fossil fuel bills? Do we look at the impact of that on ecological services and that impact on people's health, like how it all interplays? So like, what are some ways you do look at the true cost, and are there ways we can empower you to more deeply look at the true cost of our healthcare system?
Yeah, thank you for the question. I would say the biggest impact to us doing our work is some of frankly, the threats that we get when we do it.
Threats.
Yeah, remove our authorities, change them, adjust them. That's an impact.
Oh,
To do our
the
job.
political implications of you doing your job.
I would say
Yeah.
it's a limitation and it's a concern.
It's a
Right.
pressing one I hear right now too.
We're gonna leave it right there. Thank you both very much. Thank you for all your work and for coming in.
Thank you.
Appreciate it.
I did just hear the emotional cost. too.
Sure. Yeah, absolutely.
Want to just validate that.
So we are gonna stay on air and move to a committee discussion on telehealth audio only. So.
We should do it with the video off.
Oh my God.
Just, just to like show what it's like.
It's so Friday afternoon.
It is a Friday afternoon. Thank you. Thank you. So, so let's try and stay focused so that we can all get out of here. on
I need to
Friday
do
afternoon
breathing.
and go home. So telehealth audio only, we had some testimony this week. It's not the first time many members on this committee have been with this issue. And so as a reminder, DFR has been setting the reimbursement rate for the last 3 years, 22, 23, 24. They set it at a minimum of 75%. So an insurance company could reimburse at 75% or higher. That ends this year. So if we don't take action, basically we are saying, insurance companies, you figure out your reimbursement rates with providers. And if we do want to take action, then we need to take it this year. So hold on. So we heard testimony this week that I believe everyone is doing 100% for mental health. Cigna seems to be doing 100% for medical services, while the other two, Blue Cross Blue Shield and MVP, are at 75%. Doing that from memory, I hope that's accurate. And then we also heard and saw that the numbers are very small that are using this, so that there's not expected to be an increase in premiums because of it. And I don't know if everyone saw the follow-up testimony from Vermont Medical Society, but they did provide some comments from providers who have worked with patients using audio only and the value that they're seeing. So all of that said, we need to have a conversation of what we want to do. If we decide to do nothing, conversation ends. If we decide to do something, it would be a committee bill. So I'm gonna open it up.
Can you remind me, if we do nothing, are we just talking about the rate setting?
Yes.
Or are we talking that they don't have to cover audio only at all? I can't remember.
Jen, would you like to answer that?
Sure. Jennifer Carver, Legislative Council. The requirement to cover audio only would remain in statute. It's just the amount that the provider gets paid that is ending at the end of this year,
And
as far
Jen,
as what that amount is.
can you remind us it is in statute for audio visual that we have to cover at 100%, correct?
Until I believe January 1st, 2026.
Yeah, see, I knew that was a 2026 thing. Yeah, right?
Ironically, I think I was audio only during this testimony, but I was listening. And if I recall, they were arguing the payers were arguing that it should be a lesser rate? Do I read that?
No, I don't think they were arguing that it should be a lesser rate. I don't think they were arguing, I guess arguing is not the right word. I think their testimony was what they were doing now. And that, I don't think a lot of decisions had been made for 2025 yet.
Okay. I guess I'm concerned under the current dynamic of costs being cut to preserve the bottom line of insurance of payers, that this is an area where they would say, I do recall them saying that it's not being used as much as other things. I'm trying to remember this
It's very small.
testimony.
It is
Yeah,
right now.
That they might say, oh,
just
this is a small thing, but honestly, for the people I see, when we can't get the video to work, we're still using telehealth
Right.
sometimes, but we shut the video and now they can have therapy. For me to be paid less for the stress I have to go through to make that session work makes no sense. So I would rather preserve a little longer, at the quality of it, and maybe learn a little more about why that small group of people is using it and what benefit it causes them. And if that benefit is equal to an in-person session, I don't see why we would pay less. I think if we find that there's people who are using that and denying people an equal amount of care, then that would be a difference. Like if someone was not refusing to see people in person who need it and telling them they have to do it on the phone, that's different. But my experience with audio only has been the people who want to talk in psychotherapy and can't get anything else to work. And it's often still telehealth, just with the video off. So, but I know there might be other examples. So my opinion is not to mess with it for now. Maybe maintain equality, but I'm curious. I see others want to speak, so I want to hear what others have to say.
All right. Oh, sorry. Art was first, and Mari, then. Alyssa.
And this question is for Jen. If we do nothing, well, maybe not for Jen, but if we do nothing at all, will the insurance companies be able to make up what they want to pay?
Yes.
So if we do nothing, they could say, we're only going to pay 50%.
Correct.
Or is there a minimum of
There is,
75?
no,
There
the
is
minimum is going away, right, Jen? The
Okay.
minimum is
Unless we
going
add.
away.
They could
Unless
pay
we add.
1%.
Okay, so they could do anything they wanted to. They could deny it altogether probably. I don't go into, I don't have to worry about
Right,
that.
there is coverage is required under the statute. That does not go away, coverage for audio only
Okay,
telephone services. But the amount that the insurance pays the provider would be completely within the insurer or payer's discretion, as opposed to for plan years 22, 23, and 24, when the legislature gave it to DFR to define those rates.
could you review what it is right now, the percentages?
I would not be reviewing my own information. I would just be looking at testimony that you received.
So I can tell you, so DFR has set a minimum of 75%.
Okay,
And the testimony from insurers was that they tend to be doing 100% of mental health care
correct.
and 75%.
All right, okay, that is what was, I
That's
know.
what they've been doing now.
Okay, thank you.
And I just want to add one thing though. So it's in statute, audio only telephone service has to be offered, has to be covered. At the end of this year, insurance companies will be able to figure out what they can do their own thing, but they have to cover it. But it doesn't mean that providers have to do it. And so if insurance companies go too low, providers might say.
That's true.
I'm not gonna bother.
I can't
It's true.
do this because it's gonna hurt my capability, my bottom line, and we've already heard from providers who are having trouble with their bottom line. And I think, and we have heard over these years, we didn't hear it directly here this time, so you're hearing this from me, from previous testimony, we have heard providers when it was dropped down, because remember, we had it at 100% through COVID.
Right,
Then it dropped down to 75 in 2022, and we heard some providers say, we just can't make this work, and stopped offering it. So Daisy, I think, no, I'm sorry, Mari, I meant to say Alyssa and then Daisy.
Another thing that I think about is that whether it's audio or tele audio, there's the cost of the provider's time and skill That's one thing. And then there's all the other things that still happen behind the scenes, whether or not you're in the office or you're audio only, and that's staff to schedule you, staff to that do the documentation, provide pre-visit informed consent. There's the technology and making sure that that meets the requirements of confidentiality. There's the billing. So all of that stuff still happens, and those are costs and resources for the provider. So my proposal is that we have a committee bill, and we keep it at 100% for audio. And if we can add in on the audiovisual, I'll keep that at 100% as well for all of them, not just mental health, but for all of them.
You said it, I cannot.
Go ahead.
This is actually a topic I'm really passionate about, and I have been since we did this bill.
No.
So, I'm speaking from experience from somebody who has had to navigate this world after COVID hit. And I can tell you that, to Mari's point, a practice expense is just as great if you're doing an audio only visit as if you were seeing that person in person. In fact, it's actually greater because there is more administrative time that it takes to make contact with people. It's not just the provider calling somebody on the telephone. It's the provider finishing with a patient, calling, the patient doesn't answer. Then they have an administrative person try to call the person back, and then they get interrupted in a room and then go and do this visit with this person that wasn't there. There's documentation for every single visit that you have, including this, the amount of time that it takes a physician to do their documentation. And it is a office note that you're writing. And from somebody who knows coding a little bit, just to explain, an office visit code has a time component. So if you see a patient in the office for 10 minutes, and then you spent 5 to 10 minutes doing documentation, you can bill for the code for the office visit for that time. Telephone visit codes are the exact equivalent as far as time goes. So if somebody can explain to me why a doctor's time is more valuable in person than on a telephone, if you were seeing a lawyer and a lawyer was billing you billable hours, they bill you whether you were in their office or whether you were on the phone with them or sending emails. Their time is valued the same. My big push this year and in the future, we just heard Owen talk about primary care, and administrative burden is so heavy. And I can tell you, that from trying to code these visits, if you want to talk about mental health being covered at 100 as opposed to medical at 75, I'm making these determinations when I've got a claim. If it has 5 diagnosis codes on it for hypertension, diabetes, and depression, I'm having to make these mental administrative coding calculations and changing modifiers and moving around priorities of codes to try to get 75 to 100. And it's frankly an administrative nightmare to make sure you're coding to the highest level to get the proper reimbursement. So I suggest we do a committee bill, and I'm suggesting that we put it in there that audio only is just as valuable as audio visual or in person.
To continue Mari's thread of 100%, same as mental health, which I believe is an increase of 25% from where they're billing at 75%. I'm all on board.
like Alyssa, like my job before I came to Vermont was working with content folks who would go around and help providers close that gap and improve their billing practices. And so I think it's not just here, it's everywhere. This is an epidemic in terms of people who go into these medical fields wanting to help people be well. And instead, like we heard yesterday, they're spending sometimes half their time at a computer. And we know what that does to our workforce. We're living that right now when we can't find someone on the other side of the door when we need help. And it's because they don't want to sit in front of a computer. They want to help us. And so I think this is one way to improve that. And I would happily endorse doing a committee bill to work on this.
Leslie?
I agree with everybody. And I want to add two more things. Yes, committee bill. Yes, 100% audio only. If you read the comments that came from Justin Barnard, they're very poignant and important. So I think it supports a very vulnerable population that I want to do. And I also think the amount is so teeny weeny that the implication on our insurance companies is negligible. So let's do it.
Bobby?
Well, I don't have Alyssa's experience in coding and medical experience, but I know something about communication. And I grew up in a culture with a lot of hand gestures and and a lot and facial expressions everybody knows. And I feel like honestly, audio only might be less efficient for communication. You have to ask more questions. You have to say more things. So you might spend a little bit more time than if you have a person in front of you, you can read the body language. And so I agree too, that it should be equal to in person. And, and I represent a very rural district where the distances between doctor's offices might be great. And there's a lot of people who can't travel. So for that reason too, I support the committee bill and parity as well.
So we have a majority that are interested in at least doing a committee bill. That doesn't mean that we're saying, yes, we're going to pass out a committee bill. I'm interested to hear other things, but I would say that we draft a committee bill and then we continue the conversation. I'm not sure how much more testimony we're going to take because I think we've heard it. And so I'm open, but
Okay.
we've heard from everyone.
Just a couple of questions.
Yeah.
I'm new with all this stuff. Number one, if it's a telephone call, and if it's a person that cannot speak the English language, what do you do within that case? Do they have interpreters available by the phone?
Yes, they may have interpreters, or it may be a situation that is not doable by a telephone. We're not saying that everything has to be done by telephone. In fact, Jen, can you remind us of the language? There has to be consent given to do it by phone.
Yes, it has to be medically necessary and clinically appropriate to deliver
And
services.
my second question, how will that affect the insurance company's premiums?
So we heard from DFR, and I think we saw in
One of
the,
them said, no problem.
right, DFR said the cost impact is basically nothing because it is so small. Now, that doesn't mean it's going to stay small, but right now, the data that we've seen, the data is very few. And again, this is not saying we're passing out a committee bill. This is just saying we have the majority that is interested in doing a committee bill. So I'm going to ask Jen to draft some language for us and I can work with you just to do 100%.
Do you want to discuss consent?
We use
Yeah, so
it.
can you,
Oh, yeah.
yes.
I know I'm not a witness, but can I just say for the record, because I showed Penny on my computer, that at the Howard Center where I'm employed, that we have multilingual liaisons. I don't know what the term is now that we use, but that are people, but that there is a 24/7 teleinterpretation service that the agency has a contract with. And at the crisis line, if someone calls at 1 a.m. and they don't speak English, if I can figure out what language they speak and say, hold on, within minutes, you can get someone around the world to get on the phone with you and do it through the phone. And and it saves people's lives and it does again. So just for the record, we could hear from others to say that, but I would be remiss not at least answering. And I showed him on my computer, so.
Can you give us an idea of the timeline of this? When does the current structure run out and this bill we would be doing for now and it has to be crossover, et cetera?
Right, so the current ends out at the end of this plan year, so December 31st, 2024. So we would make an effective date of January, upon passage, I would think.
Aren't we have a little more leeway with committee bill?
Hold on, Art.
Yeah, no, to get rid of. Just so I understand what we're dealing with. Okay, if we leave it at 75%, then, let's go back. If we move it to 100% from 75, right now, we probably can figure out how many calls were made or how many audio only interactions were done at 75%.
Yes, we have that data from this
We have
week,
that data.
at least from Blue Cross Blue Shield, we found this week.
Okay. And so we can figure out what the impact will be to our budget. Because some of the 25% will come out of the general fund, correct?
No, it will not. Nope. Nope. This is not a change in service. This is a change in reimbursement rate. We have the capability to do that. So it does not come out of our general fund. It is an insurance potential expense.
Okay, okay, this is an insurance, okay.
Yeah. So it's not what Jen talked about with services, and now we would have to add, if we add a service to our essential health benefit, we have to go through general fund. This is changing
All
reimbursement.
right, so they will pay the other 25, and it could result that there's a lot in higher premium. It could.
Potentially.
All right,
They're already paying 100% for mental health.
all right.
And that's a much higher volume amount. Go ahead.
I just wanted to point out that Vermont Medicaid, which actually is some state dollars, they're
That's,
already paying 100%. And they said they're not changing that.
No, I believe they said they're not sure what they're doing in 2025.
Oh, really?
And that was going to be my question. If we can direct Medicaid to pay it. So let's include them in the.
As far as I know.
Yeah, I wasn't sure if there was a-
Want to give it to the extent
Yes.
permitted under federal law.
Yeah, that's what I was wondering. Yeah.
so, what was it?
So, oftentimes federal guidelines dictate Medicaid.
Sure,
And so if we direct Medicaid to do something in language, we normally say at the extent permitted by law, by federal law. So I don't know if we have the authority
that's right, we were gonna
to bring
look
that
into.
to 100%.
Okay, yep,
So
okay,
that would cover that. If they can't, federal law would let us know. Right. Second committee bill.
Yeah, finishing Daisy's question about timeline, does committee bill still have to meet policy crossover?
I looked it up.
Yes,
But you
Yes.
probably know off the top of your head.
yes.
Yes, the committee bill, so the committee bill introduction deadline is after crossover, but so functionally, if you don't get your committee bill introduced by crossover, you haven't met, you'd have to get a waiver from those committees, but.
Wait.
Yeah, and crossover is after our break, so I don't see this not an issue. I think your question was more around, when does
City bill final approval.
when does the DFR directive to pay at 75% end, and will this still get
So
through
they
in
won't
time?
actually.
No, it was both, actually.
Okay.
I'm thinking in terms of our plate, what,
Yeah, so
what has to come off in order for us to take this
nothing
up?
has to come up. Because I don't think this will take a long time for us to figure out.
Because we've already had the witnesses.
Okay. All right.
Just the day of
sorry, I'm
short.
slow on the uptake. here.
No, you're fine. Keep asking.
No, just, so what insurance company does it at 75% now?
Blue Cross Blue Shield and MVP for medical services.
Both of them?
Yeah.
For medical only,
Yeah.
get that. And we heard from them,
Yes.
and what did they say?
I believe they would like to keep it at 70. They would like to be able to determine what their.
Okay, all right, yep. Thank you.
Okay, all right, so we'll work on that. So then the only other thing I want to talk about real quick, I promise it won't take long. That's, you all ask a lot of questions.
Let's not.
Two things. If you haven't given me your bill priorities, 1, 2, 3, please do. Bill priorities, I sent you an email.
I know,
Priorities.
I can't choose.
So, so then the other thing I want to talk about is, so we had the 2 joint hearings with House corrections on the healthcare in prisons. And so Chair Emmons and I have talked, and what we want to do is put together a small group, 3 people from her committee, 3 people from this committee, to do a deep dive into the WellPath contract. So we think I know, we think that you're all gonna react like, yes, please, I'll do it.
I totally want to.
I'll do it. So anyway, let me just say, so I think what we first need to understand is what is contractually required so that we can then determine what they are not doing. So this is a long-term process. You know, it's not something we're going to finish this year. But so that would be working with corrections. You guys can all figure out how you divide it up or how you want to do it. But really doing a deep dive and coming back for healthcare specifically, like what standards are they supposed to follow? What requirements do they have to report on? Like all the important things that we would want to know.
Mhm.
And then I would also say one step further would be, well, what's missing in the contract that we would want to know and go from there.
I'd like to do it.
So hold on. So I'm not asking for volunteers yet. Let's do questions. Leslie. Then
I'm just
Daisy.
wondering if there'll be staff. I mean, it's a contract.
No, there's no staff.
So how do you interpret? I mean, I looked at the WellPath contract. It's 120 million pages. I mean, it's like 140 pages. It's a lot.
Oh, I think you could reach out to DOC with questions, but there will be no legislative staff or JFO staff on this. So
Because I'm just thinking about how do we interpret? I mean, you're
I
a
would-
non-lawyer.
I would say you look at the contract and as you're going to come up with a list of questions and you go back to DOC or whoever it is with your list of questions, just like, you know, Daisy and Melanie would do with the budget or we would do with, you know, anything that we have in front of us. But no, there is no staff to help on this one. Daisy?
That was my question. I was going to ask about resources and coordination.
So the coordination would be with the 3 members from House Corrections. And Alice and I haven't talked about timeline or anything. I mean, we know it's a big ask. So it's not like come back in a week with it. It's a big ask. It's a long process.
Might there be a chair or someone who like, so who does the logistics? Someone has to say, when are we meeting?
I would say that between the 6 people on it to figure that out. How do we work together?
So it's just 3 members, the chairs of the House and Corrections aren't involved?
We're not involved, but happy to be involved if you need us, but no, we're not involved in the deep dive. Obviously, we'll be available throughout the process to answer questions. So I don't need volunteers right now unless, but I hear 3 already. If there's more, send me an email if you're interested, and then I'll work with trying to pick 3.
I was just curious if it's beneficial to they get nonpartisan or like.
That would be great if at all possible. Yes. So
How would it be? Oh, you mean like?
Well, if it's only
Bipartisan.
Democrat. Depending on what's
Right.
So you just put like me, Art, and a Democrat.
Yeah.
I'm just saying.
We'll really
for-
get into that
for
stuff.
you,
Them and somebody
Or
else.
Penny, if you want to dig into.
And also on their side, you may have the whole mix.
yes. So
Yeah.
yes, and they have yeah, they're mixed. They've already.
They're
picked
more-
their 3.
So I'm the liaison to that committee. However, there's so much problems that if 3 other people want to dig into the WellPath contract and let me focus on everything else, that's fine. And I can just consult with you all on that because there are so many problems that from what I've in the last few days, and so many unanswered questions. And I am meeting with the commissioners, policy people next week to talk more, like out of the room because I have so many questions that I would take the whole meeting up asking. So I'm going to have my own meeting with them. So I'm happy to just continue being the liaison. If there's 3 others who are really passionate and want to be focused on the contract, but I'm also happy to be part of that 3 or be a 4th floating person. So I'm putting that out there, but I just wanted to flag that it is serious. Like the scale of inequity is pretty serious. So.
Thanks, Brian.
Can you elaborate a little bit on, if this is part of a broader process? I know there were some of us, Leslie and I were involved in some stuff between the sessions. And in looking at healthcare and prisons, and I wonder if this is part of a larger process. You mentioned that it's gonna be longer.
Yeah. I mean, yeah.
So just, is it simply about the contract or is it about, moving to a different a different place with how healthcare is delivered or?
What the end result is, I don't know, but it is a process, I think, that we have to go through to be able to get to the point where we can ask intelligent questions based on what is contracted to get to a point that we are ensuring that healthcare in prisons is being delivered in a way that we would want, standard of care that we want to give to all Vermonters. And so there's enough concern that that isn't happening. What does that mean at the end? Is it we take it over? Is it oversight of WellPath in a different way? Like I don't know. But the goal is to figure out what is contracted, what is actually happening, and then what do we do?
And did this group is there a mandate or any statutory thing that says that we have to assemble this group and go through the contract?
No, it is there's no mandate from anyone other than we got the information from Joint Justice Oversight. We had that letter, which I sent to everyone, which is what led to the two initial joint committees. And then it was, Alice and I talking about how we start the process of doing something. Joint committees isn't the most effective way to do it. There's too much to go through as one, even we can't bring it into this committee right now because there's so much to do. But, being able to dive in as a subcommittee and then bring back where you think the concerns are is a step to get us to the next step.
Great. I was the one in the joint committee that brought up the standards question and also the contract. Could you share the contract with us? And I have a ton of experience, including on the national level around patient safety and quality and standards, both leading teams at UVM Medical Center and then in specialty areas nationally. So that's why I just dived right into that kind of stuff. And it's one of my favorite things to do.
Got yourself a reference. Yeah.
That's gold.
So I'm thinking, it's the second year of the biennium and we're closing in on what, so I'm just wondering if there's a reasonable goal to have by the end of this section to set up for something from who's ever, and you've said a couple times, we don't know who's going to be in these seats in any of these committee rooms.
Yes.
So where would be a sort of a goal of a reasonable endpoint for now?
Yes.
For a step in that.
Yes. And I would think the goal would be an analysis of the contract and a listing of, questions, issues, I don't really know until we'll start going through the recommendations for what the committees could focus on, whoever is in these seats next year. I just want to bring Topper up to speed real quick. So the Justice Oversight of the Healthcare in the Prisons, we are going to form a subcommittee. So 3 people from corrections and 3 people from here to do a deep dive into the contract as a first step of determining what's even the expectations, where do we think the gaps are, what do we need to figure out next as the first step doing it. So I'm outlining that and then asking people to volunteer.
I'm on that committee.
Right. Okay. So people who are interested, send me an email and then we'll figure it out. Right.
Just to speak to Leslie's concern about a goal. Before I knew that this group was formed as the liaison to corrections, what my goal has been to look for any possible way that we can suggest improvements. For example, I asked the committee to let me testify on a bill that went there that would create a fund to integrate community-based providers into the facilities. Because right now corrections is saying the biggest barrier is insurance, but if the state created a fund to pay them, then insurance wouldn't be a barrier. But one thing we might look for in the WellPath contract, so I'm glad we're doing this, is to see what they're supposed to be doing, because we might be able to ask them to pay out of their contract for that instead of us coming up with the money. So that's one thing we might find in the contract. So what I would be looking for in terms of things we could deliver on would be clauses or phrases in the contract that we could use to say to them, we would like you to do this way, and then negotiate with them, because I do get the sense that there's wiggle room. And then another thing would be to flag things that they aren't doing and ask them to do it by the end of the year. And then maybe when the I don't know if there's a way to hold them accountable formally, but at the very least, the next body could come in and say, how did you do that over the last 6 months? How did you do that? So I think there are measurable things we could do through this. I actually appreciate the idea. And I'm also, like I said earlier, I'm happy to not be on that group as long as I'm still doing the liaison work. Because I could be the general liaison and like be consulting with that group. If there's enough people, because I think the more hands, the better on this one, because it is 100 and something pages.
Yeah, it is.
It's dense, it's
Yeah.
boring.
So I guess I'm just saying, I don't need to be on that group, but I do hope you'll let me continue to be the liaison to corrections.
Yeah, absolutely.
Okay, so let me know. And thanks for a good week. I know it wasn't easy listening to all the budget stuff, but I think everyone was engaged.
I'm gonna go home and
I appreciate that.
emotionally eat.
So